Hi there, CliniqueRN fam. I'm Madeline. Lately, multiple clients' NGN questions have been trending hard on the NCLEX, and for good reason. Today, we're breaking down how to prioritize, delegate, and think like a nurse so you can ace those high-stakes scenarios. Let's dive in. For the first question, we'll look at the various data points provided, just like in the case study scenarios on the NGN. These data points help us figure out what's important, what's not, and how to make the right nursing judgment. Take your pen and paper, write down all the data points. We'll be using them to answer every question that follows. Each one matters, so don't skip this part. The nurse is assigned to care for 4 clients on a busy medical surgical unit during the morning shift. Nursing notes. Client 1. The patient is alert and oriented 3 times, but reports fatigue and increased thirst. He states he urinated 3 times overnight and feels weak this morning. The left lower leg is red, warm to the touch, and tender with +2 pitting edema. Current IV site intact and infusing vancomycin. Capillary blood glucose measured at 318 milligrams per deciliter. Skin turgor slightly poor, and mucous membranes are dry. He denies chest pain or shortness of breath. Vital signs. Temperature 37.9 degrees Celsius. Heart rate 108 beats per minute. Blood pressure 148 over 92 millimeters of mercury. Respiratory rate 20 per minute. 95% peripheral capillary oxygen saturation on room air. Morning labs pending. Client 2. The patient is sitting upright in bed, appears flushed, and is using accessory muscles to breathe. She reports chills, shortness of breath, and a productive cough with yellow sputum. Oxygen is running at 2 liters per minute via nasal cannula. Vital signs. Temperature 39.6 degrees Celsius. Heart rate 124 beats per minute. Blood pressure 100 over 58 millimeters of mercury. Respiratory rate 30 per minute. 87% peripheral capillary oxygen saturation. Lung sounds diminished with coarse crackles in the right lower lobe. IV antibiotics, ceftriaxone, were started at 0-200. The patient's WBC count this morning is 18.7 times 10 to the power of 9 per liter. Client 3. The patient was admitted overnight following a fall at home. He is drowsy but arousable, oriented only to person. Reports headache and mild nausea. Pupils are equal but sluggish to react. Noted bruise to the right temporal area with a small laceration. Sutured in emergency department. IV fluids running at 75 milliliters per hour. Current medications. Acetaminophen IV given 2 hours ago for pain. Vital signs. Temperature 37.4 degrees Celsius. Heart rate 92 beats per minute. Blood pressure 168 over 98 millimeters of mercury. Respiratory rate 16 per minute. 97% peripheral capillary oxygen saturation on room air. CT scan result pending. Client 4. The patient is 24 hours post-thyroidectomy. She appears anxious and is speaking in a hoarse voice. Reports difficulty swallowing and tingling around her lips. On assessment, mild inspiratory stridor is audible. IV line patent. Fluids infusing at 100 milliliters per hour. Current medications. Levothyroxine held until cleared by the physician. Vital signs. Temperature 37.0 degrees Celsius. Heart rate 112 beats per minute. Blood pressure 130 over 78 millimeters of mercury. Respiratory rate 24 per minute. 94% peripheral capillary oxygen saturation on room air. So now the question. Based on the nurse's notes for all 4 clients, which client requires immediate priority assessment and intervention? Client 1, Client 2, Client 3, or Client 4? The correct option is Client 4. Let's look at the rationale for each of the options. Client 1, incorrect lowest priority. Hyperglycemia, glucose 318, and cellulitis indicate infection and poor control, but hemodynamically stable, 95% peripheral capillary oxygen. Saturation, heart rate 108, blood pressure stable. Requires intervention, fluids, insulin, continued antibiotics, but not emergent compared to airway and hypoxemia threats. Client 2, incorrect but high priority. Severe pneumonia with fever, tachypnea, and 87% peripheral capillary oxygen saturation despite oxygen, indicating hypoxemia and risk of sepsis. This client is unstable, but airway obstruction, client 4, is more immediately life-threatening than low oxygen that can be managed by escalating support. This client is next in line after securing client 4's airway. Client 3, incorrect moderate priority, post-fall with drowsiness, headache, and sluggish pupils indicates concern for possible intracranial bleed. Needs urgent neurochecks and CT, but their airway and breathing are stable. 97% peripheral capillary oxygen saturation, respiratory rate 16. This is a serious risk, but not as immediately life-threatening as stridor or hypoxemia. Client 4, correct priority. This client is 24-hour post-thyroidectomy with stridor, hoarse voice, and perioral tingling. That's classic signs of airway compromise and possible hypocalcemia due to parathyroid injury. Airway always comes first, ABCs. Stridor is a red flag for impending obstruction. This patient could lose their airway rapidly, which is an immediate priority. Let's also look at some additional notes. Central concept. Multi-client prioritization is one of the most tested NCLEX skills because it reflects real nursing practice. A nurse rarely cares for just one patient. The exam tests whether you can distinguish urgent, life-threatening cues from important but less immediate concerns. Key clinical teaching points. Airway red flags, stridor, hoarseness, inability to swallow, are signs of obstruction and require immediate action. Post-thyroidectomy clients are at high risk due to laryngeal nerve injury or hypocalcemia from parathyroid removal. Breathing red flags include hypoxemia, 90% peripheral capillary oxygen saturation, severe tachypnea, and use of accessory muscles. These clients must be stabilized promptly, but airway threats still come first. Neurological red flags include a sudden decline in consciousness or new pupillary changes. These suggest possible intracranial bleeding or rising ICP. Urgent, but after airway and breathing are secured. Metabolic or chronic issues like hyperglycemia or infection are serious but generally allow time for interventions without immediate collapse. Test-taking strategy. On the NCLEX, when you see multiple unstable clients, don't get distracted by lab numbers or chronic conditions. Ask yourself, which patient is about to crash if I don't intervene in the next 2 minutes? That patient comes first. CliniqueRN test day tip. When answering prioritization, circle every airway or breathing clue in the stem before looking at anything else. If more than one client has airway breathing concerns, pick the one with obstruction, stridor, swelling, foreign body, over the one with hypoxemia, low peripheral capillary oxygen saturation. If no airway or breathing threats are present, look for sudden neurodecline, confusion, sluggish pupils, new stroke signs. Stable but abnormal findings, like high glucose, fever, or pain, should fall to the bottom of your priority list. The NCLEX loves to trick you by presenting several sick clients, but the one with a compromised airway is always the most time-sensitive. By the way, if you want to practice these same style questions, check out the CliniqueRN QBank. It's got everything you need to level up your prep. AI feedback system that explains every answer in plain English. Cat mode so you can train under real NCLEX conditions. And a summary sheet to help you review and track your progress after every session. It's like having your own personal NCLEX coach in your pocket. You can sign up for free using the CliniqueRN link in the description and start practicing right after this video. Here's additional data point for the second scenario. Let's look at the handoff from the night shift nurse. Client 1. Slept poorly due to frequent urination. Blood glucose at 0600 was 322 milligrams per deciliter. Left leg remains swollen and red. IV vancomycin was infused overnight without complications. Client 2. Febrile throughout the night. Highest temperature of 39.8 degrees Celsius at 0500. Oxygen requirement increased from 1 liter to 2 liters overnight due to desaturation. Cough is more productive with thick yellow sputum. Client 3. became more confused at 0500, was only oriented to self, complained of headache and nausea overnight, pupils sluggish, no emesis noted, CT head is still pending. Client 4, reported tingling around lips and fingers overnight, hoarse voice this morning with mild inspiratory stridor on assessment, IV fluids infusing as ordered. Now the question. Review the shift report for the 4 clients. Highlight all findings that require immediate follow-up. Client 1, slept poorly due to frequent urination. Blood glucose at 0600 was 322 milligrams per deciliter. Left leg remains swollen and red. IV vancomycin was infused overnight without complications. Client 2, febrile throughout the night. Highest temperature of 39.8 degrees Celsius at 0500. Oxygen requirement increased from 1 liter to 2 liters overnight due to desaturation. Cough is more productive with thick yellow sputum. Client 3, became more confused at 0500, was only oriented to self. Complained of headache and nausea overnight, pupils sluggish, no emesis noted. Compression tomography of the head is still pending. Client 4, reported tingling around lips and fingers overnight. Hoarse voice this morning with mild inspiratory stridor on assessment. IV fluids infusing as ordered. Now, highlight the correct options. The findings that require immediate follow-up are: oxygen requirement increased from 1 liter to 2 liters overnight due to desaturation. More confused. Tingling around lips and fingers. And finally, hoarse voice this morning. Rationale for both correct and incorrect selections. Correct selections. Client 2, oxygen requirement increased. Indicates worsening pneumonia and declining oxygenation. A client who needs more oxygen overnight to maintain saturation is deteriorating and may progress to respiratory failure. Immediate reassessment is required. Client 3, new confusion and disorientation. Sudden neurological decline after a fall signals possible intracranial bleeding or increased intracranial pressure, ICP. Orientation changes are early, sensitive red flags, and require urgent follow-up before irreversible damage occurs. Client 4, hoarse voice with inspiratory stridor, classic airway emergency. Stridor means the airway is narrowing. Combined with hoarseness after thyroid surgery, this points to laryngeal nerve injury or airway swelling. This client must be assessed immediately to prevent obstruction. Client 4, tingling lips/fingers. Early symptoms of hypocalcemia, common after thyroidectomy when parathyroids are injured. Hypocalcemia can cause tetany and laryngospasm, which can lead to airway closure. Needs rapid intervention. Incorrect or not highlighted. Client 1, glucose 322 milligrams per deciliter. Elevated, but not an immediate threat. Hyperglycemia develops over hours, not minutes, and can be treated once the airway or breathing risks are stabilized. This is a manage today, not this minute problem. Client 1, red, swollen leg with cellulitis. Infection signs are expected for this diagnosis. While cellulitis can worsen, it won't cause sudden collapse in the next few minutes. This makes it a lower priority compared to airway or neurological decline. Client 2, fever 39.8 degrees Celsius and productive sputum. These are expected findings with pneumonia and are already being treated with antibiotics. Fever and sputum should be monitored, but do not demand immediate intervention like worsening oxygenation does. Client 3, headache and nausea. These are non-specific symptoms. They can occur with many conditions, e.g., dehydration, infection, pain, stress. They don't point strongly to a critical problem on their own. The red flag neuro cue here is new confusion and sluggish pupils, much more urgent than headache, or nausea. On the NCLEX, always prioritize specific red flags over vague complaints. CliniqueRN Test Day. Tip: when faced with highlighted questions, don't just underline everything abnormal. Instead, ask, is this expected, or does it show worsening, unstable condition? Highlight only the red flags, new neuro changes, sudden confusion, orientation loss, increasing oxygen requirement or desaturation, airway obstruction sounds, stridor, hoarseness. Electrolyte warning signs that affect the airway. Tingling means hypocalcemia. Do not highlight chronic problems. Example, cellulitis, hyperglycemia. Expected findings. Example, fever and pneumonia, pain post-op. Vague symptoms. Example, headache, nausea, unless paired with dangerous changes. Remember, the NCLEX tests if you can separate expected or stable from unexpected or unstable. Only highlight what could make your client crash quickly. All right, so let's assess the data points for the third scenario. Analyze the shift report. Client 1. Slept poorly due to frequent urination. Blood glucose at 0600 was 322 milligrams per deciliter. Left leg remains swollen and red. IV vancomycin was infused overnight without complications. Client 2. Febrile throughout the night, highest temp 39.8 degrees Celsius at 0500. Oxygen requirement increased from 1 liter to 2 liters overnight due to desaturation. Cough is more productive with thick yellow sputum. Client 3. Became more confused at 0500. Was only oriented to self. Complained of headache and nausea overnight. Pupils sluggish. No emesis noted. CT head is still pending. Client 4. Reported tingling around lips and fingers overnight. Hoarse voice this morning with mild inspiratory stridor on assessment. IV fluids infusing as ordered. Now to the main question. Review the client data. Select the most likely cause and the correct effects for the client's current condition. For client, the client's hoarse voice, inspiratory stridor, and tingling around the lips are most likely caused by 1. Hyperglycemia due to stress response. 2nd, hypocalcemia from parathyroid injury. 3rd, hyperkalemia from IV fluids. 4th, hypomagnesemia from poor intake, which leads to 1st, laryngospasm, airway obstruction. 2nd, polyuria and dehydration. 3rd, bradycardia with heart block. 4, hypotension from fluid loss. And 1, neuromuscular irritability and paresthesias. 2nd, jaundice and pruritus. 3rd, hypercapnia and drowsiness. 4th, constipation and bloating. The correct answers are hypocalcemia from parathyroid injury, laryngospasm/airway obstruction, and neuromuscular irritability and paresthesias. Let's have a look at the rationale for both correct and incorrect options. Cause: hypocalcemia from parathyroid injury. Correct matches timing and context. Early post-thyroidectomy period. Explains all cues. Tingling, paresthesias. Hoarseness/stridor, laryngospasm. Physiology: low calcium ion lowers the threshold for neuronal/muscle excitability, indicating tetany and airway spasm. Hyperglycemia from stress response. Incorrect what it causes. Polyuria, polydipsia, dehydration, blurry vision, fatigue. What it doesn't explain. Stridor and perioral tingling are not features of hyperglycemia. Mismatch. Doesn't connect to immediate post-thyroidectomy complications. Hyperkalemia from IV fluids. Incorrect typical findings. Muscle weakness, paresthesias sometimes, cardiac arrhythmias, peaked T waves. Key miss: stridor/laryngospasm is not a hyperkalemia feature. Context: no data that K-containing fluids were given. Vital signs don't hint to arrhythmia. Hypomagnesemia from poor intake. Incorrect but nuanced. Truth: low magnesium ion can cause neuromuscular irritability, and severe hypomagnesemia can reduce PTH release or action, secondarily lowering calcium ion. Why still wrong here? No risk profile, e.g. chronic alcoholism, diarrhea, diuretics, no timeline matching surgery. The primary, common, testable post-thyroidectomy cause is hypocalcemia, not isolated hypomagnesemia. Exam Pearl: even if a distractor seems plausible, pick the most direct, most likely post-operative complication that unifies all cues. Hypocalcemia. Drop down 2. Effect 1. Laryngospasm, Airway obstruction, correct direct link. Hypocalcemia means tetany of laryngeal muscles, stridor and airway threat. Priority, ABCs. This is the immediate life threat. Polyuria and dehydration. Belongs to hyperglycemia or diabetes insipidus. No fit, doesn't explain stridor/hoarseness. Bradycardia with heart block. Belongs to hyperkalemia/hypermagnesemia. Drug effects. Hypocalcemia, EKG. Prolonged QT, not typically AV block. Hypotension from fluid loss, nonspecific. Could occur in sepsis/bleeding. Not a hallmark of hypocalcemia. Drop-down 3, effect 2, neuromuscular irritability and paresthesias. Correct. Hallmark, perioral/fingertip tingling, muscle cramps/tetany are classic for low calcium ion. Matches the note. Tingling around lips and fingers. Jaundice and pruritus. Belongs to cholestasis, hepatic disease, irrelevant here. Hypercapnia and drowsiness. It could happen after prolonged hypoventilation, but it's not immediate or defining effect of acute hypocalcemia. The earliest specific signs are paresthesias/tetany, constipation and bloating. Belongs to hypercalcemia, opioid use, hypothyroidism, the opposite of hypocalcemia's neuromuscular excitability picture. Edge cases students ask about, addressing common objections. Could hoarseness be from laryngeal nerve injury instead? Yes, hoarseness alone can reflect recurrent laryngeal nerve neuropraxia or edema. But the perioral tingling plus stridor points to hypocalcemia-induced laryngospasm, which is both unifying and immediately dangerous. Treat the airway and calcium. Could neck hematoma edema cause stridor? Yes. A tense neck swelling with tracheal deviation, dysphagia, or neck pressure signs would favor hematoma edema. Here, the tingling strongly tips toward hypocalcemia as the cause of the stridor. Hypomagnesemia can mimic hypocalcemia. Why not pick it? Without risk factors, labs pointing to magnesium ion loss, and with a fresh thyroid operation, the highest yield primary cause is post-op hypocalcemia. On the NCLEX, pick the most likely, most direct complication given the context. Immediate nursing implications. What these points lead you to do next. Airway first. Elevate Hob, prepare suction, call rapid response/provider. Anticipate advanced airway if stridor worsens. Calcium now? Anticipate IV calcium gluconate per protocol. Draw serum calcium ion or magnesium ion. Obtain EKG. Watch for QT prolongation. Don't delay. This is a treat in minutes problem, not a monitor and see situation. The fourth scenario. Let's have a look at the medication administration record, MAR 0900. Client 1, vancomycin IV 1 gram every 12 hours. Last dose at 0600. Lisinopril PO 10 milligrams daily, due at 1000. Insulin Lispro per sliding scale. Blood glucose 322 milligrams per deciliter at 600. Client 2, ceftriaxone IV 2 grams every 24 hours. Last dose at 0200. Azithromycin IV 500 milligrams every 24 hours. Last dose at 0200. Acetaminophen 650 milligrams by mouth every 6 hours is needed for fever. Last dose at 0400. Oxygen via nasal cannula at 2 liters per minute. Client 3, 0.9%. NS4 at 75 milliliters per hour. Continuous. Acetaminophen 4, 1 gram Q, 8 hours. Last dose at 700 hours. No anticoagulants ordered. CT pending. Client 4 IV fluids at 100 milliliters per hour. Continuous. Levothyroxine, PO 75 micrograms daily. Held until cleared by physician. Calcium gluconate, IVPRN, if calcium 8.0 milligrams per deciliter, or if signs of hypocalcemia not yet administered. Now to the question, based on the MAR data, which nursing actions are most appropriate to take right now? Select all that apply. 1. Administer insulin Lispro for client 1's blood glucose of 322 milligrams per deciliter. 2. Hold client 1's lisinopril until blood pressure is reassessed. Third, administer another dose of acetaminophen for client 2's fever since the last dose was given at 0400. Fourth, notify the provider about client 3's lack of anticoagulant therapy following a fall and pending CT scan. 5. Prepare calcium gluconate IV for client 4, showing signs of hypocalcemia. The correct answers are 1, 2, and 5. Let's have a look at the rationale. Correct answers. First, administer insulin Lispro for client 1. Blood glucose 322 milligrams per deciliter means it requires coverage. Sliding scale is ordered, and insulin should be given promptly to control glucose and prevent worsening. Second, hold client 1's lisinopril until BP is reassessed. Current BP 148/92 millimeters of mercury, stable. But antihypertensives should not be given blindly. Always recheck BP near medtime. Holding until reassessment prevents unnecessary hypotension, especially in patients at risk. 5. Prepare calcium gluconate IV for client 4. Client has hoarseness, stridor, tingling lips or fingers means symptomatic hypocalcemia. Calcium gluconate is ordered as needed for this exact situation. Nurse should prepare, administer promptly. Incorrect answers. 3. Administer another acetaminophen for client 2. Last dose at 0400, question time is 0900, meaning only 5 hours. The next scheduled PRN dose is at least 6 hours apart. Giving too early risks overdose. The fever is being treated with antibiotics. Wait until the next dose time. Fourth, notify the provider about client 3's lack of anticoagulants. After a fall with possible head injury, anticoagulants are contraindicated until CT confirms no bleed. The absence of anticoagulants is appropriate here. Calling the provider for missing med would be unsafe. CliniqueRN Test Day Tip for SATA medication questions. Don't just check what's ordered. Think, is it safe to give right now? Use the 5 rights plus assessment. Right drug, dose, route, time, and client readiness. Common traps, giving meds too early. Example, acetaminophen before 6 hours. Administering drugs without reassessing vitals. Example, antihypertensives without BP check. Assuming a missing med is an error when it's actually withheld for safety, e.g. anticoagulants post-fall. SATA refers to select all safe and necessary right now. Scenario 5. Now, let's look at the vital signs. Time, 0400. Client 1, temperature 37.8 degrees Celsius, heart rate 104, blood pressure 150/90, respiratory rate 18, peripheral capillary, oxygen saturation 96%. Client 2, temperature 39.5 degrees Celsius, heart rate 118, blood pressure 108/64, respiratory rate 26, peripheral capillary oxygen saturation 91%, 1 liter oxygen. Client 3, temperature 37.2 degrees Celsius, heart rate 88, blood pressure 164/92, respiratory rate 16, peripheral capillary oxygen saturation 98%. Client 4, temperature 37.0 degrees Celsius, heart rate 96, blood pressure 132/80, respiratory rate 18, peripheral capillary oxygen saturation 97%. Time, 0700. Client 1, temperature 37.9 degrees Celsius, heart rate 108, blood pressure 148/92, respiratory rate 20, peripheral capillary oxygen saturation 95%. Client 2, temperature 39.6 degrees Celsius, heart rate 124, blood pressure 100/60, respiratory rate 30, peripheral capillary oxygen saturation 87%, 2 liters oxygen. Client 3, temperature 37.4 degrees Celsius, heart rate 92, blood pressure 168/98, respiratory rate 16, peripheral capillary oxygen saturation 97%. Client 4, temperature 37.0 degrees Celsius, heart rate 112, blood pressure 130/78, respiratory rate 24, peripheral capillary oxygen saturation 94%. Time 0900. Client 1, temperature 37.9 degrees Celsius, heart rate 110, blood pressure 146/94, respiratory rate 20, peripheral capillary oxygen saturation 95%. Client 2, temperature 39.6 degrees Celsius, heart rate 128, blood pressure 96/58, respiratory rate 32, peripheral capillary oxygen saturation 85%, 2 liters oxygen. Client 3, temperature 37.4 degrees Celsius, heart rate 94, blood pressure 170/100, respiratory rate 16, peripheral capillary oxygen saturation 97%. Client 4, temperature 37.0 degrees Celsius, heart rate 118, blood pressure 128/78, respiratory rate 26, peripheral capillary oxygen saturation 92%. Now, review the 6-hour vital sign trends for all 4 clients. For each client, select whether the findings indicate urgent deterioration, continue monitoring. The correct answers are as follows. Client 1, continue monitoring. Client 2, urgent deterioration. Client 3, continue monitoring. Client 4, urgent deterioration. Now the rationale. Client 1, continue monitoring vitals are relatively stable over time. Hyperglycemia persists, but no sharp deterioration, no airway breathing threats, needs insulin and ongoing cellulitis treatment, but not emergent. Client 2, urgent deterioration, peripheral capillary, oxygen saturation dropping from 91% to 87%, then 85% despite increasing oxygen. Heart rate climbing, BP trending downward, means signs of sepsis plus respiratory failure. This client is worsening and at risk for shock, must be escalated immediately. Client 3, routine care, stable vitals, no trend of deterioration. Neurostatus is still concerning, confusion, but vital signs remain steady. Classified as routine because the cue to act is based on neurochanges, not trend in vital signs. Client 4, urgent deterioration, heart rate rising, 96 to 112 then 118. Respiratory rate rising, 18 to 24 then 26. Peripheral capillary oxygen saturation falling, 97% to 94% then 92%. Combined with stridor plus hypocalcemia signs, this trend signals worsening airway compromise, requires immediate intervention, airway management plus IV calcium. CliniqueRN Test Day. Tip: for trend questions, look across time, not at single values. The NCLEX will give you numbers that look not terrible, but show a bad trajectory. Prioritize clients with peripheral capillary. Oxygen saturation is dropping despite O2 therapy. Rising heart rate plus falling blood pressure, shock or sepsis. Increasing respiratory rate, impending respiratory fatigue. Stable but abnormal, like chronic hypertension or hyperglycemia, is monitored, not urgent. On exam day, ask yourself, which patient is heading downhill fastest? That's your urgent deterioration pick. The FINALC scenario. For this scenario, we look at the reassessment, 1200. Client 1, blood glucose decreased from 322 to 198 milligrams per deciliter. Leg remains warm, red, and tender. Client 2, peripheral capillary. Oxygen saturation improved from 85% to 93% on 4 liters oxygen. Heart rate 110, blood pressure 104/64, respiratory rate 26, temperature 38.2 degrees Celsius. Client 3, alert and oriented ×3, headache resolved with acetaminophen, pupils brisk and equal. Client 4, tingling around lips resolved after IV calcium, stridor no longer audible. Peripheral capillary, oxygen saturation 96% on room air. Now the question. After implementing interventions for each client, the nurse reassesses at 1200. Drag and drop all findings that require immediate follow-up. The options are persistent leg redness, swelling, and tenderness. Client 1. Temperature 38.2 degrees Celsius despite antibiotics. Client 2. Orientation and pupils return to normal. Client 3. Peripheral capillary oxygen saturation is still dependent on 4 liters oxygen. Client 2. Stridor resolved, and peripheral capillary oxygen saturation 96% on room air. Client 4. 198 milligrams per deciliter. Client 1. The correct options are persistent leg redness, swelling, and tenderness. Client 1. 38.2 degrees Celsius despite antibiotics. Client 2. Peripheral capillary oxygen saturation is still dependent on 4 liters oxygen. Client 2. Let's dive into the rationale. Correct selections. Client 1. Persistent leg redness, swelling, tenderness. Even though glucose control improved, the cellulitis remains active. Persistent erythema and tenderness suggest the infection hasn't responded fully to antibiotics. Infection means risk of sepsis progression, especially in diabetics. This requires provider notification and close monitoring, as additional or different antibiotic therapy may be needed. Client 2. Temperature 38.2 degrees Celsius despite antibiotics. Fever decreased slightly, 39.6 to 38.2, but remains high. Ongoing fever despite antibiotics raises concern for ineffective therapy, a resistant organism, or progression toward sepsis. This finding cannot be ignored. It needs follow-up labs, cultures, or escalation of treatment. Client 2. Peripheral capillary. Oxygen saturation is still dependent on 4 liters oxygen. Although peripheral capillary oxygen saturation improved from 85% to 93%, the patient is still on high oxygen support to maintain safe levels. A stable client should maintain oxygenation closer to baseline with minimal O2 support. The nurse must follow up, reassess breath sounds, and prepare for possible escalation of care. Incorrect selections. Client 3. Orientation and pupils are normal. This shows the resolution of neurodecline after the fall. Alert times 3 with brisk pupils means a good outcome. No immediate follow-up needed. This is a positive response, not a red flag. Client 4. Stridor resolved, peripheral capillary oxygen saturation, 96% R. A stridor and tingling were the biggest airway threats. Resolution after 4 calcium indicates treatment worked. 96% on room air means stable oxygenation. This is an improvement, not a cue for urgent follow-up. Client 1. Blood glucose reduced to 198 milligrams per deciliter, down from 322, moving toward the target range. Still above normal but improving means not requiring immediate follow-up. Ongoing management is appropriate, but this is a positive response. CliniqueRN test day. Tip: on outcome reassessment items, don't confuse better than before with safe and resolved. Immediate follow-up indicates what remains unstable, unresolved, or still abnormal. Look for persistent infection, fever, cellulitis, redness. Oxygen dependence. Client still requires high flow to stay 90%. Vitals not returning to baseline despite treatment. Ignore true improvements. Example, resolved stridor, normalized pupils. Rule: highlight what's still a threat, not what's improving. And that wraps up our NGN case study questions. Remember, every data point tells a story, and mastering how to connect them helps you think like a real nurse. If you found this helpful, don't forget to like, subscribe, and drop a comment below. And hey, you can sign up for free using the CliniqueRN link in the description to keep practicing and boost your NCLEX confidence. See you in the next one.